Hello, good evening and good day to everyone. It's good to be back. And as you can see, we have another very special guest tonight with us. And if you don't know Dr. Diana Obidniak already, she's here with us. And I'm very, very excited to have you back as our presenter. Our sessions are always amazing. And I have no doubt that today we are going to have another amazing session. So, Dr. Diana, it's definitely good to have you back here. And how are you feeling tonight?
Great. Thank you so much for your kind presentation. It's always a pleasure to join my NVF answers. So thank you for your kind invitation, and I'm very excited. I'm looking forward to represent you very interesting topic, very painful topic, and I'm looking forward to answer your personal questions.
Excellent. Thank you so much, of course, indeed. And yes, we will start off with the presentation, and afterwards it will be time for your questions. So as always, just put those in the chat section after the presentation. Dr. Diana will answer them for you. And I just also want to mention that Dr. Diana, she is right now in St. Petersburg, Russia, and she's the head of Art of Birth Clinic, which is a brand new clinic as well. And she also, we will first of all start with a little bit of a video, right, Dr. Diana?
Yes, certainly.
Perfect. So before I will play the video, I just also want to mention that, as you know, myivfanswers.com, we are part of European Fertility Society, and we are here every single day to support you, to give you an opportunity to ask your own questions. And well, definitely we have strange times, but I hope that those events are just helping you, even if a little, then we are very happy that we are able to do it. Okay, and well, let's go ahead with the video first, okay? So you can have a look at the clinic Art of Birth and St. Petersburg. So let me just play it, okay?
In the last 40 years, more than 8 million babies have been born through IVF globally. And Russia is among top countries with the highest IVF success rate. St. Petersburg gathered the best specialists in ART, who founded the Association for Human Reproduction. Today we present a high-tech Art of Birth clinic, opened in St. Petersburg, Russia.
Dear patients, we are glad to present you a new scientific and clinical center of assisted reproductive technology with own genetic lab. Collaborating with 3 main universities in St. Petersburg, we provide individual and complex approach to each couple. We approved our expertise in so-called toughest cases. Precisely, recurrent implantation failure, poor ovarian reserve, and severe endometriosis. Applying our own unique algorithm practice, we declare 95% of success in 3 attempts. That's why we have a lot of international patients coming to us. We know how inspiring can be someone's experience. That's why today one of our patients, Lucia, is ready to share with you her history.
Hello, I'm Lucia. In 2019 we arrived to St. Petersburg because of my husband's job. And at the time I was already looking for a baby and I have some problem. And it was a success only when I met Dr. Diana. And now I am the happiest mother of Clara Miriam.
Diana is not only a treating doctor, but also a CEO of her own surrogacy agency, ISA Fertility.
As a physician, I'm used to take responsibilities for all the stages of process and guarantee the best quality of services for my patient. That's why several years ago I determined to establish my surrogacy agency called ISA Fertility.
My name is Masha and I work in the international surrogacy agency ISA Fertility. We speak your language, study the laws of your country and accompany the whole cycle of the surrogacy program. People from more than 18 countries come to our agency. I lived in China for several years and I understand that the competence in the field of surrogacy and IVF in St. Petersburg is now at a very high international level.
Welcome to St. Petersburg, to the Art of Birth Clinic, to the ISA Fertility Agency.
All right, excellent. So thank you so much for showing this to us as well. Definitely looks really, really nice. So thanks a lot for sharing that. And now I guess it's time for our presentation on our very, very interesting topic, right, Dr. Diana?
For sure, for sure. We're totally
Let's
ready.
go ahead then, of course.
So, dear guests, I'm very pleased to see so many patients today. So, for me, I'm sorry, all of you are for sure persons, but I'm so used to the word patients. So today, we will discuss very interesting and very painful topic for both for physicians and for patients. We will talk about recurrent miscarriages, the causes and prospects for patients. Unfortunately, this problem is still actual, and sometimes patients think that after IVF, given the intensive development of our technologies, we observe lower rate of miscarriage. Unfortunately, we see the contrast. The risk of recurrent miscarriage is higher after IVF than in general population. According to all the studies and trials on this topic, we know that even the risk of bleeding at early stages of gestation is twofold higher in pregnancy after IVF. No doubt there are a lot of risk factors, and today I will try to highlight all of them. Unfortunately, given our limited time, I will discuss each of these risk factors very briefly to have opportunity to answer your personal questions. So we associate advanced reproductive age, obesity, endometrial pathology, endometriosis with recurrent miscarriage. Always, we certainly know that the type of embryo transfer, precisely our choice, if we want to make frozen embryo transfer, also called fresh embryo transfer, will make impact on the result. Also, we know that our technology, our choice of luteal support also may play a very bad role in pregnancy course. And for sure, there are a lot of concomitant pathology will may have impact. From the other side, we know that the factor of infertility, fertilization method do not make any impact on pregnancy course. So if we talk about advanced reproductive age, seems evident that when advancing women's age, we observe higher rate of miscarriage. Precisely, if we talk about patients after 36 years old, we see that the rate of miscarriage makes higher and higher, with being dramatic after 42 years old. The very interesting moment that the difference we see very slight difference if we talk about frozen embryo transfer and fresh embryo transfer. So in both cases, we see significantly higher risk in women of advanced reproductive age. Also, obesity. We talk and we name obesity when we have body mass index higher than 30. So we know that, and we see it in our practice, that obesity always make an impact. But as we have evidence-based medicine, we always try to improve our hypothesis and our experience. So I want to share with you a very interesting paper on trial on obesity. So this study included more than 2,500 cases of miscarriages. About 63.8% was caused by abnormalities in embryos, but in cases with normal karyotype of embryos, we see that more than half of women suffered with obesity. So for sure, before planning the pregnancy, we want to assess all the risks and prevent them if it's possible. So also the other investigation on BMI associates also with so-called polycystic ovarian syndrome, PCOS. Maybe you know that PCOS is very closely associated with obesity, and sometimes it's the very reason caused obesity. So we see that in all the ranges of age, in all the groups of age, we see that obesity plays a bad role and makes an impact on outcome. Especially it's associated in groups of women after 35 years old, but PCOS as a separate reason doesn't make any impact on miscarriage, but obesity for sure elevates risk of miscarriage. The other risk factor is alterations in endometrium. If you saw the previous webinar on recurrent implantation failure, you know that I pay much attention on endometrium because it's the precious tissue where our embryos makes implantation. So the cavity of your uterus is an apartment for future pregnancy. That's why we should be totally persuaded that the conditions inside the uterus and the condition of endometrium is very good. Sometimes, unfortunately, we observe inflammatory process, so-called chronic endometritis. Chronic endometritis is a condition involving the breakdown or the peaceful coexistence between microorganisms and the host immune system in the endometrium, resulting in a special type of chronic inflammation in the endometrium. We know that the prevalence of chronic endometritis differ from study group. If we talk just about general population with no certain problems with fertility, we will observe just 10% of cases with chronic endometritis. But if we talk about recurrent pregnancy loss, this rate is rather high and is close to 66%. We know this and it seems rather natural because unfortunately miscarriage is the trigger for formation of inflammation process. That's why even one case of miscarriage will result in chronic endometritis, and we should pay much attention to preparation of endometrium to prevent the risk of recurrent pregnancy loss. The other condition and the other disease which is very close to endometritis, but it's separate disease called endometriosis. It's a very difficult condition and it always makes bad impact on different types of and aspects of fertilization, of implantation, and for pregnancy course also. I want to present you a prospective trial included 600 persons. In patients with endometriosis, live birth rate is always lower, and unfortunately, miscarriage rate is much higher. It's not associated with abnormalities in embryos. That's why even after pre-implantation genetic testing of embryos, when we know that the embryo is approved and is certainly normal, unfortunately, without therapy of endometriosis before embryo transfer or before planning spontaneous pregnancy, we will see very high rate of miscarriage. I have mentioned already that the type and of embryo transfer always is very significant aspect in our preparation. Nowadays, we see that frozen embryo transfer are becoming more and more popular, and I know why, and I support this tendency because for us it's really safe procedure for everybody. We prevent the risk of syndrome of hyperstimulation in first cycle, and we see that outcomes are always better. Miscarriage rate is high also in first cycles, and rate of early bleedings at early stages of pregnancies are also high in fresh cycles. That's why in our clinic we usually prefer frozen embryo transfer, as nowadays the technology of freezing of the embryos is very safe and we do not expect any risk from this procedure. The other systemic review included 11 trials, approved my sentences about the risk of early bleeding in fresh embryo transfers. The other very important and sometimes underestimated aspect is our medication support. You know that after embryo transfer and before embryo transfer, we administer medication. After embryo transfer, we make support for your pregnancy, and sometimes an improper luteal support will provide miscarriage. So why it's so important? The question support or to support or not to support, it's not even actual right now. We all know the right answer. We know that luteal phase in stimulated cycles is always compromised because of several factors, precisely ovarian stimulation per se, supraphysiological levels of steroid hormones, estradiol and progesterone, also long-term pituitary downregulation of luteinization hormones always results in luteal phase defect. We see it also in morphological changes in the endometrium. When we make first cycles, we make ovarian stimulation. And our aim is to grow many follicles, multiple follicles, to obtain as many eggs as we can. But as in our organism, and precisely in feminine reproductive system, the ovaries and the uterus are strongly associated. We see that our technology of ovarian stimulation results in accelerated achievement of pre-ovulatory status in your endometrium. So in simple words, your endometrium grows faster than it should grow. That's why there is just asynchrony of development of the follicles and endometrium. That's why we know that obviously compromised luteal phase after ovarian stimulation causes the absolute need for artificial support. But we know that we need to support. The question is how. According to Cochrane review, we know that there are different types of preparation and administration of progesterone. We can administer progesterone per vagina, in oral forms, in mode of injections, and according to the evidence-based medicine, we know that effectiveness of these routes are quite close, so we call it equally effective. However, in our real life, we see that this standardized preparation sometimes is not good for everybody. And under these circumstances, most fertility specialists are inclined to favor standardization of luteal support in their practice, and we see that sometimes pregnancies suffer from this standardization. I always tell my team of doctors and my patients that for sure we all are different, and evidence-based medicine will show us which mode of the therapy are better, but always there are about 20% of patients which inquire individualized approach even in such standardized form of therapy. That's why in our practice we assess all the risk before making administration, and sometimes also according to available evidence-based data, we make combination of different forms of progesterone and make better results and see better results afterwards. When we talk about recurrent miscarriage, for sure we should plan for pregnancy beforehand and prevent all the risk beforehand. In our practice, we call it optimization of assisted reproductive technology treatment. So the first line is no doubt pre-implantation genetic testing of embryos, because about 80% of miscarriages especially in women of advanced reproductive age, are associated with abnormalities of the embryos. Then we make always selective embryo transfer. So we make transfer of one embryo, and we discuss this approach with patients. We explain why it's better, and it seems very evident when you think over it, because multiple pregnancy always associates with many concerns, with elevated risk, not only with miscarriage at the early stages, but also with preterm childbirth and delivery. That's why sometimes patients are afraid of selective embryo transfer, because in their mind, as many embryos we will transfer to the uterus, the more embryos we transfer to the uterus, the more chances we have to get pregnancy. But our aim is healthy baby. It's not just positive test after embryo transfer. That's why we usually just in 95% we make embryo transfer of just one embryo. Then we make individualized proper luteal support, and in tough cases we recommend adjuvant treatment. I will tell you what I mean when calling adjuvant treatment. These are the data about pre-implantation genetic testing, and if you see that if you pay attention to the slide, there is a comparison between pre-implantation between cycles of assisted reproductive technology with pre-implantation genetic testing and without it. You see that the number of embryos which we transfer in the practice is a bit lower in cycles with pre-implantation genetic testing, but the rate of delivery is twofold higher in cycles with pre-implantation genetic testing. The rate of miscarriage is much higher in cycles without pre-implantation genetic testing. So it's about 39%, and the number of the percent of miscarriages in cycle with pre-implantation genetic testing in this trial is about 2.7%. But for sure, pre-implantation genetic testing is not just problem solving of miscarriage as the whole problem. I want to share with you one very interesting trial. It included about close to 300 cases. All these cases were with one embryo transfer with pre-implantation genetic testing, and the authors declare the clinical pregnancy rate being 51.2%. However, miscarriage rate was 17.3%. And I want to pay your attention that close to 14.5% was associated with recurrent miscarriage in medical history. That's why for sure we should make pre-implantation genetic testing, but we shouldn't stop with applying just this technology. We should do our best and add some supplements and adjuvant treatment to prevent the risk which are not associated with aneuploidy in embryos. The other very significant aspect is proper luteal support, proper progesterone. For sure, according to all the actual guidelines, we prefer so-called micronized progesterone, which is more natural one. But there are different modes of medications, one in form of gel, the other in form of capsule, and it seems that they are very similar. But if we pay attention to the clinical pregnancy rate, we see that when using the progesterone in form of gel, we see much higher clinical pregnancy rate, and the abortion rate is very low. I think that it can be associated with the form of gel. It's more resistant one. The other aspect is that when we use and administer capsules, we have to administer it 3 times a day, and in contrast to the gel when we administer it just once a day. For sure, when we have to administer and to insert capsules per vagina for many times per day, it's associated with enhanced elevated risk of mistake, and sometimes patients just forget about another dosage which should be inserted, and it provokes a risk of miscarriage also. When I have mentioned adjuvant therapy, I meant a granulocyte colony-stimulated factor. To say the truth, by this time, unfortunately, it's the only approved method to minimize risk of recurrent miscarriage. I want to explain you why. It's not the synthetic hormone and stimulating factor which is not familiar to our organism. In contrast, women produce granulocyte colony stimulating growth factor, applying for many aspects in reproductive area. Granulocyte colony stimulated factor, or GCSF, plays a great role in implantation, in ovulation also, and for sure in pregnancy course. You see on your slide that there is a comparison between pregnancies when the authors applied GCSF with no medication and when they used other medication. You see that the pregnancy rate is much higher. It's about 2-fold higher than cases with no medication and other medication, and the live birth rate is much higher. By this time, we know that it's very safe procedure, and we can make injection of GCSF during up to 40 days after we have approval of ongoing pregnancy. And we use it in cases both of recurrent implantation failure and in cases of recurrent miscarriage. I want to share with you that GCSF is used not only for recurrent miscarriage, but we have very good data about recurrent implantation failure and even in cases with resistant thin endometria. I know that there is an often situation when patient after several miscarriages has altered endometrium, and sometimes we observe that endometrium is very resistant and it doesn't respond to our standardized therapy, and that's why we have to use this so-called regenerative medicine and administer GCSF to make it more healthier and obtain normal response to our therapy and normal growth of endometrium. These are also data illustrating that the miscarriage rate is much lower when applying GCSF. When talking about take-home message and what I wanted to tell you in this brief presentation, because I understand that it's very hard to highlight all the aspects. That's why I wanted to make it briefly just to get you closer to this problem. According to our algorithm, we know that in patients with recurrent miscarriage, we do need to plan for pregnancy beforehand. We always evaluate all the risk factors, and sometimes it takes 2 or 3 months when we have to administer very specific examinations, but it works evaluating all these aspects beforehand. We know that nowadays the first line of technology applied is pre-implantation genetic testing. We always prefer to make embryo transfer in delayed cycles even when we do not perform pre-implantation genetic testing. Because when we make PGTA, we always have to, according to the technology, we always will make frozen told embryo transfers. After that, we make investigation and make individualized appropriate luteal support. And in patients with recurrent implantation, with recurrent pregnancy loss, we are inclined to administer granulocyte colon stimulating growth factors. We have very, very good results. I would like to share with you case report. It's the patient of 42 years old. She had multiple pregnancy losses before it resulted in infertility. So she came to us with the diagnosis of infertility associated with endometriosis. By that time, she already had resection of both ovaries, so she had low AMH. We had antral follicle count being 4, but we have normal rate of sperm analysis. By that time, she already had 12 ineffective embryo transfers during 3 years in another clinic. But just 2 of them were with preimplantation genetic testing. What we performed, as she had very diminished antral follicle count, we applied moderate stimulation in the embryo banking program with following PGTA. She wanted to have 2 babies. That's why our aim was to obtain at least 2 blastocysts with normal karyotype. In my opinion, we always try not to make, unnecessary technologies, unnecessary attempts. That's why after we obtained 2 blastocysts, we started to prepare her uterus. Due to recurrent miscarriage and the risk of chronic endometritis, we performed hysteroscopy and deleted polyp of endometria. Then we make anti-inflammatory therapy, and when we were and investigated the rate of reciters of estrogens in endometrium to make individualized luteal phase support. When we were ready, we performed frozen thought embryo transfer with following injections of colony-stimulating growth factor. We had, from the first attempt, good results. So pretty girl was born via cesarean section, and you have seen the start of this case in the beginning of our meeting. So Lucia was precisely this woman with a successful attempt in our clinic. Now I'm very ready to answer all your questions. I hope my presentation was useful for you, and now I'm ready to talk more and answer your personal questions and your history.
And as always, thank you so much, Dr. Diana. It's great to have you back indeed. You have explained everything. But now it is time for all the questions. And as you can see, there are some of those ready. And just, of course, if you haven't asked yet, go ahead and do it now, okay? And let's have a look at the very first question that we've got right here. Do you recommend PGTA in embryos derived from donor eggs?
Yes, certainly. We recommend, because we even in this presentation, I haven't included the slide of the several trials investigating already the PGTA results in egg donation program. But just trust me, because we have even our personal intensive experience that we know that male factor always make impact on development of the embryos. That's why in a situation when husband or partner is older than 40 years old, or he has some abnormalities in sperm analysis, it's always recommended to make PGTA. And we see that about from 20 to 50% in egg donation program of the embryos are abnormal. It's very precious information, because I want you to pay attention that we make very strict examination and investigation of the donors beforehand. So we even make trial fertilization of the donors of the egg with the donor sperm, just to be sure that the quality of the eggs is perfect. However, in a situation when we make egg donation program with fertilization with sperm with some defects, we always see that there is negative selection and some of the embryos are with several abnormalities. So yes, I strongly recommend PGTA even in egg donation program.
Excellent. Thank you so much for for a great question, that's for sure. And thank you so much, of course, for your advice and recommendations as well. Okay, let's have a look at this one. So what antibiotics you usually prescribe for CE, and for how many days if no culture available?
Well, for sure, we do not like so-called empiric antibiotic administration. So we always make investigation of the culture in the uterus, because we know that it's in most cases it's a mixed culture, and there are several pathogens which should be treated by antibiotics, but the choice of antibiotics will be different according to all the trials, because by this time we have a lot of trials on the culture inside the uterus. We know that chronic endometritis is associated with Gardnerella. That's why we usually administer antibiotics which are very painful for this mode of pathogens. And usually we have to administer it not less than for 10 days. But after that, we should make controlling biopsy of the endometrium to be sure that this treatment was successful. Only after that we can go on and follow the next step.
All right, again, thank you so much for explaining yet another question. And now let me go to next question from Babu. Okay, so when you include GCSF in a medication plan, will there be no other medication aside from estrogen and progesterone in a transfer cycle, frozen transfer? I mean, drugs like prednisone, ASS, or heparin.
Thank you for a great question, because it's this is a question from dramatic medical history. I see it and I know it. There are in medicine there are also some trends, and for several years ago we saw a trend that we should administer prednisone, ASS, and heparin, but we do not make it widely. According to actual data, we know that there are specific conditions when it's useful, but in wide practice, unfortunately, it doesn't make any benefits. However, these medications are not indifferent, so we should be very, very accurate when administering these medications. It's a rare situation when we administer prednisone. Usually, I make this administration when there are some autoimmune problems, for example, with thyroid. If you have autoimmune process in thyroid, it's an indication to make in very, very low dosage of prednisone. Please don't administer it by yourself. Always make a consultation with your physician. If we talk about ASS and heparin, we should control the blood, because sometimes if we make it without controlling the blood levels, blood rate, we can produce the risk of bleeding because of our administration of this medication. So please be very accurate. And in my point of view, we shouldn't make administration of many medication, because you should take into the account that all the medication will make contractivity with each other. That's why we are inclined to administer not more than 4 medications in whole.
And that makes perfect sense, of course. Thank you so much for yet another thorough explanation. And let's have a look at the next question, okay? So, are there cheaper biosimilar to originator GCSF?
Well, for sure, there are different names in different countries. In Europe, it's widespread so-called leucostim. It's the original medication. The cheaper one is Nupomax. And there are several cheaper biosimilar, but they are not that effective as we expect. So we use in our practice the original medication called leucostim and the biosimilar Nupomax.
And thank you for that. And of course, there was a thank you from our previous patient as well. And next question is here, if you can explain this. Are there any differences between PGTA, PGD24, and NGS24?
Well, these are different names of the same procedure. PGTA is pre-implantation genetic testing of the embryos. NGS24 is just a certain name of technology assessing by which we make pre-implantation genetic testing of the embryos. Normally, when we call pre-implantation, when we tell pre-implantation genetic testing, we mean NGS24, but I know that sometimes in some clinics make ERACGH and call it PGTA, but it's not very good idea. It's better to use PGTA only when using NGS24. PGD24, it's a rare situation when we use that name because it's just, a combination of two names. So it's not the correct one. We should use PGTA. It means pre-implantation genetic testing of the embryos, because we can make pre-implantation genetic testing of the PGTM when making investigation on monogenic diseases. And NGS24, it means that we perform pre-implantation genetic testing of all the chromosomes. So these are names of quite similar investigations, but NGS24 it always means PGTA, and sometimes PGTA it can be not only about NGS24, but sometimes physicians mentioning PGTA give description about ERACGH, but it's also not very correct.
Wonderful. Thank you so much for the explanation. That can be definitely confusing. Lots of different shortcuts, but also those names are changing sometimes as well, right? So
For sure.
it's sometimes hard to keep up with the changes. But thank you so much for explaining this again. And of course, there's a thank you from Julia. And
Thank
another
you.
question is up. In an egg donation program, is age of the recipient a risk factor for miscarriage?
Well, yes, for sure. As we started our presentation, that advanced reproductive age is associated with elevated miscarriage, and for sure the main reason of this association is that in patients of advanced reproductive age, we see the higher rate of abnormal embryos, abnormal genetic condition of the embryos. But even when we talk about egg donation program, we should take into the account that when getting older and older, for sure we collect many diseases, which play a role of concomitant pathology, which also makes also make impact on pregnancy course. And that's why, for sure, the age of recipient is a risk factor for miscarriage. But thank God we have a very good statistics. So we see that when we apply individualized luteal phase support, we make it in more intensive mode to prevent the risk associated with concomitant pathology and with the age. We can minimize the risk factor for miscarriage in egg donation program associated with the age of recipient.
Thank you so much. Actually, from Bubble for you. Okay,
Thank you.
excellent. And let's have a look at next question. Do you use any systemic immune suppression such as intralipids, IVIG, etc. in case of recurrent miscarriages?
The same situation with this systemic immune suppression. About 10 years ago, it was very fancy trend in medicine, and we all try to use it because our aim is to help patients with recurrent miscarriages. Because for physicians who are specialized in such tough cases, it's also very difficult. We share with you, we can relate your pain. That's why we really do our best. So we want to try all the new suggestions and proposals in therapy to obtain good results. And about 10 years ago, we started this practice. At that time, it was just like a pilot investigations, but times goes, and now we know that it's not that effective, and we use it only when we have specific indications, not associated with recurrent miscarriages. It usually associated with also immune defects or antiphospholipid syndrome. Or as we always as we work with tough patients, sometimes there are patients after oncology or transplantation of organ transplantation. Only in that group of patients we can use such medication, but it's not the wide practice. So I do not recommend it to all the patients suffering from recurrent miscarriages.
And as always, thank you so much for yet another thorough explanation to this interesting question, indeed, of course, as well. And thanks from Eva here as well. Okay, next question again. Interesting. What is your opinion on the Chicago blood test to identify cause of miscarriage?
It's a very interesting initiative, and now we are collecting our own experience on that. To say the truth, we do not have such intensive experience on that, and it's it's not considered right now as an evidence-based medicine, so we cannot recommend it as a routine practice. But it can be as the suggestion to use IVIG or intralipids, and after some years of applying, we will understand that it's not that effective and it's not that prospective as we wanted. Or it can be as a granulocyte colony stimulating growth factor approved technology to minimize the risk of miscarriage. So by this time, unfortunately, I cannot provide you, objective information, because we still collect the information and collect our own experience and available literature on this topic.
Oh, of course. So thank you so much. And that means it's just one more of those methods that we still need to wait for some
Yes.
more evidence-based support here. Yeah. Okay, at least for now, there is no question, but of course, someone is typing, and I definitely want to make sure that you have asked all of your questions. If not, remember that it's always possible for you to get in touch with Dr. Diana, and I'm sure she will be happy to help you out, and she and her team, of course, as well. And while we are waiting for some other questions, perhaps because someone is typing, I want to ask in such case, Dr. Diana, it's a little bit of topic, but of course, regarding current situation, are you having patients from abroad as well at your clinic?
Yes, for sure. We have very close relationships with the Ministry of Foreigners. So, as we are associated with universities and with scientific work, we have a very good reputation. That's why we have a specific offer for our patients. So we organize so-called medical visa. It takes about 3 weeks, from 3 to 4 weeks. After that, you can come to St. Petersburg for 90 days. It's more than enough for in our practice, because we usually prepare our treatment to make it in 2 weeks. Or if we talk about embryo transfer, it will take just 2 days. But we prepare and we help our patients to organize their trip also. So
Okay.
by this time, it doesn't make any problem.
That's great to hear, of course. Thank you so much for answering that, my additional question. But of course, everyone is definitely interested to know how exactly it works. It can be different. Yeah, I can see we have a friend here.
Yes.
It's nice, yeah. I know, actually, mine was walking around here and I was a little bit worried, but all is okay. So we cannot just keep them somewhere else. That's true. That's
I
not
want to
possible.
tell you that my cat always is very perceptive. So he feels the auditorium. It means that we have very, very good auditorium. So he wanted to say hello to everybody.
Yes, they do that a lot. That's true. But we like it, right? So thank you for stopping by, right? All right. Thank you so much. And actually, in the meantime, we do have 2 additional questions. Let's have a look. So after how many miscarriages do you think one should really stop IVF treatment?
It's a very good question, but I think I would be a bad advisor, because I'm the person who never gives up, and I always try to inspire my patients and support them. We always, stay in touch after IVF treatment and just go hand on hand for several years after. I think that. To say the truth, it's a rare situation when we have to stop without any result. Sometimes, in the toughest cases, when we know that there was so many dramatic situations that unfortunately it's very risky to make embryo transfer to the uterus of patient, we apply surrogacy program. But to say the truth, it's in case of miscarriages, it's the rare situation. So my mode of view that after each miscarriage we should stop a bit and just make evaluation of all the risk factors once again. But miscarriages, it's not the situation when we have to be desperate. We have enough technologies and enough tools to make your pregnancy progressive. That's why I don't think that anybody should stop IVF treatment because of miscarriages. But for sure, each our program should be considered as the program which should be positive and which should result in healthy baby. That's why we should do our best each time. In the toughest cases, at the line of desperation, we can make surrogacy program. But in most cases, we even don't need to make it. We have good results in patients with recurrent miscarriages. So never give up.
Perfect. That definitely sounds encouraging. Thank you so much for that then. Okay, and let's have a look. Okay, there are like 2 questions left. We will be slowly finishing, so if you have anything left, go ahead and type those in. And Emily has added, so after surgery to evacuate the remains following a miscarriage, do you recommend a hysteroscopy prior to next round of IVF?
Certainly, yes. It's a golden standard of preparation on the endometrium, and the very significant moment is that hysteroscopy prior the attempt of embryo transfer, not the stimulation, but embryo transfer, should be done as close as possible. So we usually try to make it hysteroscopy, then we make the following cycle or the second cycle after hysteroscopy the embryo transfer. So for sure we make it. It's for us golden standard of preparation of the endometrium.
Excellent. Thank you so much for this as well. And that might be our, no, sorry, not final, but let's have a look. What is the maximum age of patients in an egg donation program at your clinic?
We have aspects associated with legal system. So in Russia, we can make embryo transfer for in patient's uterus for women not older than 50 years old. So we had to say the truth, a lot of programs with patients after 45, 46 years old. The maximum age when we performed the embryo transfer to the uterus of the patient was 50 years old. And we had to say the truth, 2 babies, because the second round, she wanted during all her life, she was dreaming about 2 babies, boy and girl. So 2 years after, we made a surrogacy program because it's just not safe to make embryo transfer for patients after 50 years old. But now she has her dream in real life. She has a boy and girl. So the answer is that if you mean the embryo transfer to the uterus of patient, the maximum age is 50 years old.
And again, thank you so much indeed. And actually, we have a follow-up, okay, from the previous patient. So my clinic has requested a Hycosi. Which one is it?
Hycosi. To say the truth, I didn't understand Hycosi. What does it?
Okay, if you, Nalini, if you can perhaps give us some more. Yeah, we have here the whole thing. Hysteroscoping or contrast sonography. Okay.
No, it's not the same thing, and it doesn't make any clue to say the truth, because it doesn't make any sense to say the truth, because the benefit of hysteroscopy that we insert the camera inside the uterus, so it's much more objective that routine ultrasounds can. And the good thing that when we insert the camera, we can just fix all the problems we see. So we have objective information of the condition of the uterus. We make the final diagnosis, but just at the same moment, we can fix that problem and prepare endometrium for following embryo transfer. When we talk about Hycosi and hysteroscopy, we can make just a diagnosis of the uterus with not that objective method, so we can just visualize the shadow of the uterus. It's not that objective than a hysteroscopy, and for sure it doesn't allow us to fix the problem just on the same moment. So usually if the physician recommends to make this hysterosalpingography, after that there can be indications to make hysteroscopy. That's why for us it's not the best practice, because we always want to minimize our intervention. I never allow my physician to make a lot of additional, investigation, lab tests, especially invasive procedures. So for me, it's not a good situation.
And again, thank you so much for yet another excellent explanation. And of course, there is a thank you. Okay, again, we might have our final question. So, how long after miscarriage would you recommend transferring a donor embryo?
Well, we have recommended time frames for recovery. It's 3 months, so 3 menstrual cycles, and usually to minimize the interval between pregnancies, we try to make preparation during the 3rd menstrual cycle after miscarriage. So we perform hysteroscopy during the 3rd or the 4th menstrual cycle. Then we make preparation with medication if necessary, and make embryo transfer as soon as possible, but not earlier than in 3 months after miscarriage.
Understood, of course. Thank you so much. Okay. Again, someone is typing. I'm not sure if it's a question or thank you. But of course, as you can see, there are some thank yous. Thank you so much for your answer and your motivation. Indeed.
Thank you.
Thanks from another patient for you. And of course, there was a previous patient that also wanted to say thanks for your help. And yeah, I believe we will be finishing for tonight, as we have more thank yous coming up. But of course, remember that if you wish to get in touch with Dr. Diana, I'm sure she'll be more than happy to help you out. And actually, I'm not sure if you realize, because the thing is that I have very good news. If you haven't asked something today, you will have a chance to ask your questions tomorrow, because Dr. Diana will be back with us once again, of course, on another topic. But of course, you can join us at 8 p.m. UK time again, and we will be more than happy to help you out as well, of course. Dr. Diana, right? We will be here tomorrow.
Thank you so much for sharing this evening with me, with Caroline, with my IVF answers. Thank you for your time. It was a pleasant time. I hope that my presentation was helpful for you, and I wish you and just that your dream come true. I know how significant and how important pregnancy planning is for each woman, and how dramatic and painful can be the case of miscarriage. I do relate, and I want to tell you once again that please don't give up. We do have enough tools to help you. And I know that in your country you also have physicians who are able to help you. So please don't give up. Everything will be good.
All right, amazing. Thank you so much. And of course, there's nothing really else to add. We are definitely keeping our fingers crossed for all of you. And yeah, that will be it for tonight. But of course, thank you so much. Again, you can see some comments, Dr. Diana. And I just want to mention that, as you know, this has been recorded. So if you missed any parts of it, or you wish to just simply rewatch this, it will be available tomorrow on my IVF Answers, but also our YouTube channel. So go ahead and subscribe. That way you know where the new video is uploaded. And as you know, as I mentioned, tomorrow Dr. Diana is back at 8 p.m. UK time. Join us, and I'm sure she'll be more than happy to answer some more of your questions. And you can bet she has another interesting presentation to show. Okay, so so hope to see you tomorrow. And Dr. Diana, definitely see you
Thank you.
tomorrow. Thank you so much. Have a lovely
Thank you.
evening. And well, for you it's like more of a good night, right, Dr. Diana? So
Certainly.
have a good
It's
night.
just
And
midnight.
to every, exactly, it's after midnight, exactly. So yes, thank you so much for staying up with us here tonight as well in such case. And of course, see you tomorrow. Okay,
See you tomorrow.
perfect.
Thank you.
Thank you. Bye.
Bye.